Well, Blinatumomab has been now explored in ALL for many years, and it's very obvious that there is a learning curve that we have went through. When we started out with Blinatumomab, we didn't really know if this would lead to a higher rate of cytokine release syndrome, for example, what would be the rate of neurotoxicity. And the first clinical trials, yes, indeed, there was a safety signal for both those toxicities, which are novel to this kind of therapy and very different from normal chemotherapy. And the rate was in the roughly somewhere between 15 to 20% of being severe, so grade 3 or grade 4, but no patient was lost. By getting more experience identifying who would be at risk for getting a cytokine release syndrome, we have now developed a scheme that patients with high tumor burden, defined by LDH, for example, beyond 500 at relapsing with the ALL, or with a high bone marrow involvement, that those patients would definitely benefit from a tumor reduction by giving them steroids or cyclophosphamide. And with those measures, the rate of cytokine release syndrome has been brought down to 5% now in the Tower trial, which is the phase 3 trial comparing it to SOC chemotherapy. And that's just grade 3 cytokine release syndromes, which were all manageable, so no patient was lost. And then the advantage of Blinatumomab is, even if you discover that you will have a patient like that, you just can turn off the infusion, and the short half-life of Blinatumomab of 2 hours helps here to curb the syndrome very quickly. So hence, no patient was lost in the clinical trial due to cytokine release syndrome in all the Blinatumomab trials so far. So the second toxicity that is being attributed to Blinatumomab is neurotoxicity. It has been seen with lymphoma patients in the ballpark of about 25%, grade 3, grade 4, leading to stopping the infusion. In ALL, in the first trials, we were talking something between 15 to 20%. But now in the phase 3 trial, it was brought down to single-digit numbers of 9%. And which is due to perhaps educating the physicians what is neurotoxicity, also in how to manage it. And I think also what was a surprising result, that also in the chemotherapy arm, 8% of patients had also grade 3, grade 4 neurotoxicity, which was surprising to us to see that. So overall, the safety concern of neurotoxicity, in my mind, has been actually now quite well contained. And again, no patient was lost due to neurotoxicity, which is very important, just looking at the recent data that has been coming out with other kinds of T-cell engaging immunotherapies targeting CD19 with CAR T-cells, where you do lose patients due to neurotoxicity. So that's quite a benefit in this context for Blinatumomab. And also, if it becomes difficult to handle, you always can stop infusion, and it is clinically reversible also in the phase 3 trial within 48 hours. And patients can be re-infused again, depending on what kind of neurotoxicity was seen. You can also perhaps, if it is seizure, for example, apply then neuroleptic medication that would prevent the second onset of neurotoxicity. So I think that is sort of very good to see that these two toxicities that have been attributed to Blinatumomab have been now put into the right context and are also quite manageable in the hands of the investigator. The second thing, which I think is very important, an outcome of the Tower trial in terms of the safety profile, is when you compare that to the patients receiving chemotherapy, is that the rate of neutropenia and infections was lower by quite a margin. It's probably due to the fact that Blinatumomab itself had a higher response rate, so the neutrophils could recover and contribute to protecting the patient from infections. I think that is one hallmark. And secondly, the mode of action is not of blinatumomab. It doesn't directly destroy healthy neutrophils as chemotherapy does. So those two things are contributing to this advance of providing a safer therapy to our patients in that context.
Well, if it can reduce toxicity compared to standard chemotherapy, and if the toxicities that come with it can be managed to, like you say, equivalent to chemotherapy, when should one not use blinatumomab? And if it is being used with these toxicities being so very well managed, is that still retaining the clinical benefit by turning off the infusion? Does that then reduce outcomes, or? Because it sounds like it's almost too good to be true.
It is, I think, the question when to use blinatumomab really is driven by the efficacy of the drug. And there is a poster here, or a talk actually today here at EHA, which looks at patients treated in the first salvage versus second and third salvage. And it's quite obvious that patients in the first salvage do very well, have also quite an extension of their life when compared to chemotherapy treated with blinatumomab. So I don't see any reason for a patient not getting blinatumomab in first salvage, as the efficacy is really quite remarkable, with more than doubling the overall survival for those patients, getting close to a year, which is quite an advantage in that situation. And with the reduction of severe safety issues, it speaks a clear language when to use it. In my mind, the hierarchy of how to treat patients with relapsed refractory ALL is first line would be blinatumomab, and then second line would be then chemotherapy, not the other way around. It's just driven by efficacy, by safety profile, and also by quality of life, which is also apparently higher for patients receiving blinatumomab.